Thank you. I bring you greetings from Craig McClure, who's supposed to be actually presenting this talk, but is not able to be with you here today because he had to go to a management meeting in Johannesburg. So I'll try and make it sharp, and I realize that in this meeting there's very little on elimination of mother-to-child transmission, and I just want to appreciate the presentation by my colleague from Malawi on how making it simple can achieve so much in a short time. So, I need to go. Yeah. So, as an outline, I just want to talk about the global plan to eliminate mother-to-child transmission, the goals and targets within that plan and why they've been set the way they've been set. I also want to illustrate how the MNCH platform can be an entry point for treatment as prevention, and try and make the argument whether it's a viable platform, and then look at the WHO guidelines 2010, and then moving on to the update that's just been released on option B and B+, and to look at how the shifting from this can actually help us and some of the remaining challenges. I just need to know where. Yeah, all right, okay. So the global plan was launched last year at the high-level meeting in New York, HIV meeting, with the goal to reduce new pediatric infections by 90%, and also the second goal is to reduce the number of HIV-related mortality in women. Now, just looking at this, we grappled for a long time about this whole discussion on elimination and whether we can actually eliminate mother-to-child transmission. And there were a lot of people in the room, statisticians, who felt that this was an impossible goal and that we should actually not move with this agenda. There were issues related to whether we call it virtual elimination, whether we call it effective elimination, but just highlighting here the modeling that was done by Mary Mahy and some of us at UNAIDS, looking at the contribution of what we call the four-pronged strategy for PMTCT, which has been in being since 2001, and really illustrating that if we do nothing in the blue line, we're going to end up with 367,000 children newly infected with HIV by 2015, but that by operationalizing and really scaling up to 90% access to the 2010 WHO guidelines, we could reduce that number to 138,000, which was a 60% reduction. And that if we added reduction of new infection in women, so 50% reduction in incidence of HIV infection in women of the reproductive age group, adding unmet need for family planning, we could actually get down to 73%, and that if we did something about breastfeeding, that would go down to 79%. So you can see that from the modeling, looking at 25 high-burden countries, we're not going to get to zero, but we will get closer to where we want to be. So linked to that discussion was also the understanding that when you look at women coming to antenatal facilities, and the key question is around how many of these women will actually need treatment and how many will need preventive therapy for PMTCT. This is work done in Zambia by Louise Kuhn and colleagues. This was a study that was looking at breastfeeding transmission risk, but they analyzed the MTCT and mortality by eligibility for ART with the current WHO criteria cutoff of 350 for CD4, and then looked at transmission risk as well as mortality in women. Just to say that when you looked at transmission at 6 weeks, you can see that the transmission was much, much higher, 16.7% in women that were eligible for treatment, and that's the 68% in the pie chart there. And that post 6 weeks, transmission actually continued, 17% compared to 4.2% in women that were not eligible. Now, when you look at mortality 24 months on, 92% of the women who were eligible would have died, looking at this data. So basically, moving on, apart from mortality, the whole issue of infection, new infection in women was also looked at. And the issue that women entering antenatal care, actually, when you look at how many of those women are infected at the time of delivery or during lactation, you have new infections of 3.4% in South Africa. In Malawi, Taha reported 2.9%, and then in Zimbabwe, Jean Humphreys actually reported 3%. But also to highlight the high transmission risk that you see actually in these women. So the issue of what we do about prevention, I think, is a key issue for PMTCT, and as we talk about treatment as prevention, we need to come back to this issue. So I'm proposing that as a platform, when you look at the MCH platform, we really have two people here that we have to deal with. We have the pregnant woman who has to be tested. We have their partner who also equally needs to be tested and identified. And then going down, we're talking about what we do with the HIV positive pregnant woman. And I think the approach here is that we want to give them what is optimal for them, what is optimal for their child, and what is optimal for their partner. So basically, ART could actually improve all these outcomes. And then we look at the negative woman. We're looking at what we know about their partner, how do we get them tested, get them into care, and wrap around some interventions to make sure that this woman remains negative and doesn't transmit to her child, but also we're optimizing care and treatment for their partner. So the platform, the MCH, could be an optimal entry for treatment as prevention. So looking at the 2010 guidelines, we, for a long time, working in the HIV PMTCT community, were actually accused for ignoring the issue of the woman herself and what she needs for her own health, and that we focused for a very long time on just prevention of mother-to-child transmission. But just to say that in the 2010 guidelines, it was very clear that we needed to treat the woman who, for their own health, and the cutoff was 350, as I said, and that for women that did not need treatment, we needed to give them antiretroviral therapy, AZT at that time, with single-dose nevirapine at delivery, and then continuing single-dose nevirapine to the baby, which was called option A. I just want to highlight this, and I'll come back to this discussion. And then option B was actually triple therapy to the pregnant woman, continuing through breastfeeding. And of course, the breastfeeding risk is the reason why we needed the extended nevirapine, and we didn't have very good data at the time beyond 6 months of what nevirapine would do, but then we had some information around triple therapy. But just to say that, looking at what countries then did, by April 2012, a lot of the countries have adopted these guidelines, and except for 2 where we're still negotiating and advocating to make sure that happens, that's Angola and India, but the rest of the countries have. But I want to highlight that most of the countries have adopted option A. And the conversation in the countries have been quite interesting. First of all, most countries think that option A is easier to deliver. When we're discussing the guidelines, a lot of the effort and the discussion was not about operational feasibility. It was about what we know with the science that we have. And it was very clear that if we're able to identify women who needed treatment, option A would actually fare very well with option B. But I just want to highlight this analysis of cost effectiveness. And these are the discussions that are happening in the countries as we speak. So basically, when you look at the different options, 2006 scenario A, which is option A, and then option B, you find that actually when you look at infections averted, option A and option B with this model data is not doing too badly. But when you look at the cost of what it will take to deliver option A or option B, this is where the discussion in the countries is. Nobody's talking about operational feasibility, they're talking about cost. And they're actually reflecting back how many women they're going to have to treat, what does this mean for them? So the discussion then becomes option A is easier, but actually option A may not be easier. So I just want to highlight this study that was presented by Gatland at just the ended CROI conference, looking at, they randomized sites in Zambia, rural Zambia, looking at triple therapy, so option B approach, and looking at the standard of care in Zambia, which is option A. And just to highlight that the results, when you look at the 6 months cumulative actually infection risk, what you find that the control sites, 13% of the children were either infected or dead compared to the intervention site, and that this infection actually continued 19.8% by 12 months. I just want to highlight that although Zambia has decided on option A, they have real issues with the tail of option A, which is nevirapine single dose extended therapy for the baby, and a lot of these sites did not have the extended therapy. So much of the postnatal transmission might also be related to that fact. I also want to highlight something else, which I think is extremely important as we think about treatment as prevention and elimination of mother-to-child transmission. This is work that was done by Mary Glenn Fowler, reported at CROI in Uganda, looking at what happens to women who at delivery have a baseline CD4 350 to 549, or baseline CD4 more than 550, and looking at how many of them 6 months post-delivery or 12 months post-delivery actually progress to CD4 deterioration less than 350. And I just want to highlight the middle part there where when you look at CD4 400 to 449 and look at how many of the women actually dropped to 350 by 6 months, it was 26.2% and 36.9% by 12 months. So again, looking at this data and the guidelines that we have and the operational feasibility and problems that we have, I think we need to interpret this data in the context of what makes it simple and easier to implement. The last slide that I want to show on this issue is related to the duration of the intervention in relation to transmission risk. And this is data by Hoffman looking at duration of HAART in pregnancy and transmission. If a woman started HAART before delivery, the transmission risk in this study was 5.7, but looking at up to 4 weeks, 9.3, going down to 3.5 if the woman had had HAART for more than 32 weeks. Again, I think the implications of this study comes back to the point that do we actually know how to operationalize these scientific findings, and are the guidelines that we are developing actually applicable and feasible and operationalizable at the end of the day? So I just want, with that background, I want to talk about what opportunities do we have with the new update from WHO, looking at shifting from A to B and to B+. I really think that this gives us the opportunity to simplify treatment for women and to optimize protection and prevention. And the idea that we can actually start triple therapy or ART to pregnant women, knowing that their fertility rates, like they did in Malawi, are high, and knowing that deterioration of CD4 is likely to happen in about over 30% of women. Do we really want to stop and start with option B? I think that's a critical question that countries need to look at. We have actually started looking at this and trying to model what this means in 21 high-burden countries that are part of the global plan, and using some of these assumptions. And we estimate that by using the option B+, we can actually save over 20,000 more children between 2013 and 2015. And this work is continuing, and we hope that we can publish this paper soon. I just want to come back to the issue of male engagement. I think I did make the point that new infection is a problem. Male engagement in a lot of our programs is extremely low, but looking at Rwanda and seeing what they've been able to achieve from 2003 to 2010, I think the idea that if there's political commitment and if people are able to look at this critically, we can achieve up to 81% testing in men is something that we need to look at. But I think one critical question that we need, which is still unanswered, is how do you define a partner? I just want to show you some data from a recent study, which was an impact study that was done in South Africa, looking at children at 6 weeks, and looking at the marital status of the mother for that child. I was actually quite surprised that in South Africa, in this particular study where we had over 6,000 unexposed infants and over 3,000 exposed infants, only 20% of the mothers who were HIV positive actually said they were married or cohabiting with somebody, and 26.9% in those mothers that were negative. So do we really understand what the patterns of partnerships are in Africa? If you go to East and Central, I don't have the slide for East Africa, that data is probably reversed. You'll probably find more partnerships in East Africa than you have in Southern Africa. So we really do need to understand these concepts moving forward. So what do we need to do? What next? I just want to end my presentation by looking at the critical bottlenecks that we have to unbottle for moving forward. So these are the countries, and for elimination, we need to focus on what is the unfinished agenda. And just to introduce to you that in working in this area, the IATT and UNICEF have actually developed an analysis tool that starts to unpack where are the disparities, what is happening across the care continuum, and where do we need to focus, and where do we need to put our investments. And this is just a schema of a bottleneck analysis in one of the countries, looking at what the countries themselves defined as the tracer indicators they wanted to look at across the country. I just want to mention that a lot of what we see in PMTCT is very much related to the MCH platform. In this particular country, if you look at ANC1, which is the third bar, 89% of women were actually coming for ANC. Testing rates for this country was actually quite high. It was almost 87%. But you look at ANC4, and you see that 53% of women are actually coming for ANC4. Maternal ARVs is very closely linked to that. So the whole issue of where we're putting our investments, what is the integration agenda, how do we use our HIV dollars to actually improve the performance of the MCH platform is something we need to look at. Using this bottleneck analysis too, we've done this in 10 countries. I just want to leave you with some of the things that we are finding as the limiting steps to getting to where we need to be. On the supply side of the program, human resource capacity, as we cascade down to the lower level facilities in these countries, is a real issue. The whole issue of CD4 screening and also the early infant diagnosis, major issue. The supply chain, the commodity security in some of these countries. I talked about Zambia, where although the guidelines talk about giving nevirapine to babies, in most of the sites, the nevirapine is not there. So on the demand side, we're finding that user fees for maternal health are a limiting factor. Limited community engagement and support is also an issue. And on the overarching, I just want to talk about the monitoring and evaluation. To do the bottleneck analysis, we're having to rely on the data in those countries, and we're finding major bottlenecks with the data that we have. So in conclusion, I just want to say that the maternal, newborn, and child health platform is an important entry point for treatment as prevention. I hope you agree with me. And that the option B plus, might simplify access to optimal therapy treatment for mothers and their partners and their children. And switching to option B and B plus has the potential to serve many more children and probably mothers by 2015 in Africa. Influencing planning and prioritizing investments will be key, and I hope that I've convinced you that we really need to look at the disparities and the key bottlenecks to implementation. And some of these gray areas will really need people like you to innovate and also study what might be the most optimal approach with good evaluation platforms. Thank you.